Thanks for joining us today on Lincoln Fire and Rescue. Today we are at Station 1 at 18th and Q, and we're going to be talking about sudden cardiac arrest and the survival of sudden cardiac arrest and the differences between a heart attack and sudden cardiac arrest. And we have the experts here today. We have Rescue Division Chief Roger Bonine, and we have Dr. Jason Kruger, the EMS Medical Director for Lincoln Fire and Rescue. Roger, Jason, thank you very much for coming in.
Thank you.
Sudden cardiac arrest. Jason, how sudden is a sudden cardiac arrest?
Well, sudden cardiac arrest can happen immediately. And when we're talking about sudden cardiac arrest, we're talking about when someone's heart stops, they lose consciousness, and clinically they're dead.
Is that the same, or what is the difference between that and a heart attack?
So a heart attack typically occurs when someone has a blockage in one of their coronary arteries. Most frequently results in someone having chest pain, being nauseous, short of breath, sweating. Frequently people will go to the hospital or call 911 because they're feeling pretty awful, typically as they're having a heart attack. Heart attacks, if untreated, or even if treated promptly, can result in somebody going into a full cardiac arrest where their heart completely stops and they stop breathing. But they're just subtly different.
But a sudden cardiac arrest, Roger, you can confirm this too, your EMTs have probably had to respond to something like this. It is sudden, and you don't have to have a heart attack that leads into sudden cardiac arrest?
That's correct.
So you can have, there are three things that it could possibly be. You could have a heart attack without sudden cardiac arrest.
Yes.
You could have a sudden cardiac arrest where you just drop to the floor.
Correct.
Or you could have both.
Correct.
That's correct.
A heart attack then that leads into, which of those three would be the most common?
I would say the most common clinical picture is somebody's having a heart attack. They're having chest discomfort, they're not feeling well, and due to the severity of the blockage, it throws off the electrical system in the heart. And the heart goes into an erratic rhythm, something called ventricular fibrillation, where the heart just starts fibrillating and people lose a pulse. They no longer have a pulse. There's no effective blood being pushed through their coronary arteries. There's no blood going to their brain, and they would suddenly drop at that point.
What does a heart attack feel like?
Most classically, somebody would be having substernal chest discomfort, shortness of breath, nausea, weakness,
Pressure?
diaphoretic pressure, typically. The nerves inside the heart aren't really the same kind of nerves that we have in our fingertips where we can really identify the difference between sharp, dull, hot, cold. Then when the heart is experiencing pain, a lot of times it's very nonspecific. People feel a heaviness, a discomfort, they just don't feel well. Some people, like diabetics, sometimes women experience very different symptoms where they're just, not feeling well or feeling weak and they're having a heart attack.
What does a sudden cardiac arrest feel like?
Well, a sudden cardiac arrest, people lose feeling. We read books about things like these where people describe what it felt like after their heart stopped. People can sometimes still hear, and make out little bits and can remember little events around their sudden cardiac arrest, especially people that, are getting high quality CPR, maybe still have a little bit of mental function.
A person is not dead or dies as an immediate result of sudden cardiac arrest?
When somebody's in sudden cardiac arrest and their heart's not beating, we would say they're clinically dead. But with effective CPR, defibrillation, and aggressive medical treatment, we can bring some of those people back from the dead.
That's where your EMTs come in. What kind of special training, Roger, is necessary to be able to respond to a heart attack that may lead into a sudden cardiac arrest right before your very eyes or in the ambulance, or it's already happened?
Well, we have 6 frontline medic units in Lincoln, Nebraska, and every medic unit has a paramedic that's been through paramedic school. They're certified by the state, and almost all of them have the National Registry certification as well. So they've been trained to deal with cardiac arrest and heart attacks, other types of medical problems, as well as trauma and other things. Our EMTs all take CPR. They have gone through enough education to pass their EMT class, and then they also do continuing educations, and they're certified and licensed by the state of Nebraska.
What equipment is on an ambulance to
All
handle that?
All of our ambulances have LifePak 15 defibrillators, cardiac monitors, defibrillators. So Dr. Kruger mentioned when the heart is fibrillating, it's there, the patient's called in VFib. We can use an electrical current to try to wipe that rhythm out so the heart can restart on its own.
Are those the paddles
Yes.
that we stereotypically
Not anymore,
see?
but yeah,
No?
they show them on TV.
What are they these
We use
days?
pads. We use gel pads that stick to the chest.
And Lincoln has how many of these devices? Every ambulance has?
Every ambulance has, I believe we have 32 or 33 LifePak 15s, plus we have 8 LifePak 1000 AEDs, which are it's a simpler device.
What is the difference, or what are the differences between that device and the Lucas 2?
Well, the Lucas 2 is a mechanical chest compression device. It provides mechanical chest compressions, whereas the defibrillator is a cardiac monitor. Like you see on TV, we put leads in different places, and we can run 12 lead EKGs, transmit those to the hospital, and then we can actually look at that heart rhythm. Our defibrillators also have the ability to defibrillate, whereas the Lucas device is just a mechanical CPR device.
Jason, how long has that technology been in Lincoln? The transmission of that EKG reading live as the ambulance is transporting this?
I believe we started our 12-lead EKG transmission program around 2007 or 2008.
Something like that.
Where we could do EKGs in the field and transmit that data to the hospital before the patient even arrived at the hospital, so that the emergency physicians and the cardiologists had a pretty good idea of what was going on, again, before the patient even hit our front doors at the hospital.
And because minutes count, or even seconds count, that makes a difference.
Oh, absolutely.
Oh, absolutely. One of the things that's best about our program, rather than driving yourself to the hospital when you're having a heart attack, you call 911. Our goal is when we get there, we'll do a 12-lead EKG within 5 minutes and transmit that to the hospital, and we'll make it a cardiac alert. That way the physicians, they can activate the cath lab personnel, and they can all be waiting there rather than have to get
Ask
down there.
questions and
Right.
transmit that information.
The cath lab people will be there waiting rather than have to respond after the patient gets to the hospital. It saves quite a bit of time.
Any idea yet what the survival rate, or how that improves the survival rate?
Nationally, several years ago, the American Heart Association came out with recommendations that hospitals have door-to-balloon times in 90 minutes for patients that are having heart attacks, or if they've got a blockage in one of their coronary arteries and they go to the hospital, we want to open up that artery within 90 minutes. Within Lincoln, beyond our hospital door-to-balloon times, our 911 to balloon times are under 70 minutes. So that if somebody's having a heart attack in Lincoln and they pick up the phone and call 911 having chest pain and they've got a blocked artery, they're going to have that artery opened up in slightly around an hour, which is really amazing because, I mean, 10 years ago, when the American Heart Association came out with these recommendations for hospital door-to-balloon times of 90 minutes, really the physician community and the hospital community is like, I don't even think we can do this, getting, you know, the cath lab staff and our cardiologists in that quickly. And now we're seeing hospital door-to-balloon times of under 30 minutes. We've seen some as low as about 10, 11-minute door-to-balloon times in the hospital, because we can activate the cath lab before we even start transporting the patient. And it pains me as an ER doctor, but completely bypass the emergency department and go straight to the cath lab, where we can get that artery opened up immediately.
The balloon is the opening of the artery,
Correct.
the device that opens up the artery.
Yeah.
I've said this before, that Lincoln is a good place to have a heart attack. So given that statement, take me into the culture, Roger and Jason. Why is it so important in LFR and emergency medical to be a community like this? Because it takes a community consciousness. We're going to talk about Pulse Point here in a second, and that's another very successful application that citizens have taken a hold of. But what is it? There are cities, larger and smaller, that don't have this culture. Help me understand the medical and emergency culture that feels it's necessary to have Lincoln be this responsive.
Well, the one thing I would say is it's teamwork. It isn't just the fire department, it isn't just the hospitals, it isn't the cardiology groups, it's everybody working together. You know, we have meetings, we discuss what we think will work, we'll try them, we measure, and then we try to improve. So it's a team effort. It's not just one individual group doing good work. I mean, they all do good work, but it's the teamwork, the team effort that makes it work the way it does.
There's no LFR versus EMS versus hospital.
No, exactly what Chief Bonine said. I mean, it's a system that saves lives. It's not an individual person. It's everything, everybody working together on the same page. And, you know, it's not hard, but it's not easy. But we've got a very good culture here that strives for kind of excellence in patient care.
I know you can't put a price, a dollar sign on saving lives, but is it an expensive endeavor to have this level of technology and commitment and staff to keep up these numbers the way you would like to keep them up?
Yes, it is expensive. I mean, there's manpower, staffing, you know, the expense of the vehicles, the equipment, but you can't really put a price on that, you know, and I wouldn't even know how to begin to do that.
The Lucas 2s, if we could refer back to them, how many
Sure.
does Lincoln have now? And if I understand the budgets correctly, there's an effort to get more of them.
Right, we currently have 4 out on the streets right now. The first one, we started a trial back in August of 2014. In January of 2015, we bought one. Our EMS supervisors carry that in the back of their EMS supervisor vehicle. We obtained a grant through the Leona Helmsley Charitable Trust for 6 more devices. We received 3 of them last fall, and they've just recently put on medic units, medics 5, 6, and 8. Sometime after March, the second grant period will be open, and we'll get 3 more, and then those will go on our other 3 frontline medic units.
Let's hope everyone watching us today is familiar with PulsePoint. But if they're not, it's an app you can download, and then you can basically cherry pick what you want. For me, I have the response calls, the hazardous material calls, the structure fires, the emergencies. That's good in my business in radio, but you can also have other a la carte features of PulsePoint.
Well, you can pick what you want to see.
Right.
Like there's expanded traffic crashes. That's a pretty popular one. That's not just
I get those.
a fender bender. That's more of what we would consider a rescue alarm here. And then there's hazardous materials responses. Those are usually a little bit more escalated. I subscribe to those. The most important thing about that is, I think, the notification of cardiac arrest, of sudden cardiac arrest in a public place. So if you subscribe to that, you automatically subscribe to that. But if someone would be in cardiac arrest within a quarter of a mile of where you're located, you're going to receive the tone on your phone, and it'll say that there's a cardiac arrest at this address. That we don't send anybody to private residences. It has to be a public place. And it'll also give you a notification of where the closest AED is.
So as we're sitting here at 18th and Q, PulsePoint could go off and say there is an event at 19th and Q.
Absolutely.
Correct.
And if I feel confident enough in my abilities, I could walk a block and respond to this call, correct?
That's
Correct.
correct.
And people are doing that
Yes.
in Lincoln.
Yes.
And that's called bystander CPR?
Correct. I mean, if somebody were to show up and start doing chest compressions, we would consider that bystander CPR. And that's really a critical piece in the chain of survival, is having a community, having people that are willing to do bystander CPR. Because when someone's heart suddenly stops, there's no blood going through their coronary arteries and there's no blood going to their brain. So not a lot of good things are happening for them. And the thing that's going to save their life is high-quality chest compressions that'll move blood through their coronary arteries and move blood to their brain until we can get a defibrillator on scene, where hopefully we can shock their heart back into a perfusing rhythm, get a pulse back, and save their life.
Oh, but Roger and Jason, I want to do something to help this person, but I'm not trained in CPR.
Chest compressions are so vitally important when somebody's heart's not beating. And we encourage people, you know, get on your hands and knees, push hard and fast on the chest. You're not going to do any damage to the patient. I mean, if their heart isn't beating, the only bad thing that could happen is nobody's doing anything. If we can do good chest compressions, we dramatically increase that person's chance of survival.
Better to do something than to not do something at all.
Absolutely. And if people download the PulsePoint app, they can look at that. You know, if they scroll through there, there's instructions on how to do CPR. You can look in the, you know, it's one of the features of the app that tells you what to do. And we don't expect people to do mouth-to-mouth anymore. I know that used to be a critical function of CPR. So when we talk about that, we want people to do chest compressions. Get down and do chest compressions. Call 911 and get on the chest and start doing the compressions.
Yeah, I wanted to point that out too. If I do feel a little antsy, get on the phone, call 911, and they can talk you through it.
And we've been working with our dispatchers. In PulsePoint, this comes out of our dispatch agency. So if you get on scene, there's likely going to be a dispatcher talking with somebody, and they are very highly trained to tell people and instruct them how to do chest compressions, only CPR. So if you're willing to do chest compressions, there's going to be a dispatcher on the phone that's going to talk you through that to give you some reassurance and confidence that you're doing it right.
Never met a firefighter yet that didn't want to get better. Never met a doctor that didn't want to improve. So where do you go from here? How do you reduce time and bump up survival rates?
Well, I think the most important thing is, you know, we started measuring our performance a few years ago. So we look at that all the time, and we're always looking for a way to improve our performance. So we measure and improve. That's kind of our mantra.
How about from the physician's perspective?
The things that absolutely save lives in sudden cardiac arrest are high-quality chest compressions and early defibrillation. From a hospital standpoint, from a physician standpoint, we're starting to see the benefit of getting these people to the cath lab promptly, because a number of these patients in cardiac arrest have a blockage in one of their coronary arteries, or as we were talking about earlier, they had a heart attack that led them into this. And if we can get that blocked artery opened up quicker, they're going to get better heart function, a better chance of walking out of the hospital. And we've started cooling these patients now, where we bring their temperatures down in order to preserve brain function. And we're seeing much better outcomes with these people getting out of the hospital and going back to work and going back to their families.
There's your homework. Download the PulsePoint app. Study it, learn it, just become familiar with it. It's an amazing tool.
It is.
For interest, regardless of what your involvement wants to be in the community. You could respond to the heart incidents. You could learn where there are traffic incidents. So that on your way home or your way to work, you can avoid some of these.
We only have about 300 firefighters in Lincoln. If we could get another, you know, and I think we've got another 6,000 now first responders following our PulsePoint app. If we can get tens of thousands of people following this, our bystander CPR rates are going to improve. And we don't care about necessarily percentages, but that's going to mean more people are going to walk out of the hospital alive from this and get back to their families.
Thank you for taking time from your busy day, Jason, for coming into Station 1, and Roger for allowing us into Station 1, you and the other administration from LFR for letting us come here and talk about sudden cardiac arrest and heart attacks.
You're very welcome.
Hey, thank you.
Thanks everybody for joining us on 5 City TV.
incredible rescue, all thanks to a very smart app for your smartphone. Well, watch this big man spring it into action. We got a message.
Pulse Point is active in Lincoln and free in the App Store. Download it today. You could be the one.